I work as an orthodontist in the Faculty of Dentistry UITM in Sungai Buloh, Malaysia. The founding dean of the faculty is none other than Prof. Dr. Muhammad Ibrahim Abu Hassan, the man who's been illuminating our Wednesday evenings with interesting topics and presentations. So thank you, Prof. Dato, for the past 2 years. Now, before diving into the core of the presentation, allow me please to walk you through a familiar daily scenario for all dentists, whether you are in public sector, private sector, or you're in academia. A patient walks through the door into your clinic. The patient usually having either pain or concern or a complaint, or could be just coming for regular checkup. You will start your assessment as soon as the patient walks through the door. And then you talk to the patient, you take information, medical and dental history, ask about the complaint, then examine the patient extraorally and intraorally, focusing on the area of complaint. You're doing all this, and your objective is to reach differential diagnosis or a tentative diagnosis so that you can proceed to plan your treatment. For without a diagnosis, we cannot formulate a treatment plan to help our patient. Now, if after the clinical examination, we are still in doubt and we need to confirm the diagnosis or eliminate a certain possibility, then we proceed to further investigation. All our goal is to reach a diagnosis and plan the treatment to help our patient. The most commonly used investigation in dentistry is the radiological investigation. Well, in fact, radiographs are not only used in diagnosis and treatment planning, they are used to monitor the disease progress, to assess the treatment efficacy in some cases. So they are far beyond only diagnosis and treatment planning. Now, according to the International Atomic Energy Agency, in their statement that's updated for 2020, dental examinations are the most frequent type of radiological procedures. They account for 21% on a global scale. That's about 1/5 of the radiological procedure, and that's a large number. Radiological examination in dentistry was used only 2 weeks after it was developed by Röntgen in 1895. So Röntgen developed the first radiograph in December 1895, and Dr. Wolkoff in Germany took this image of his molars in the first week of 1896, just few weeks after the initial development of the X-ray. And then it was followed by Dr. Edmund Keel in the USA, where he, in the coming months, developed and improved the intraoral radiograph. Then we get the cephalometrics in the 30s, the panoramic in the 60s, but up until the 70s, what we have was only 2-dimensional pictures of the complex maxillofacial structures, which are 3-dimensional. Then in the 70s came the computed tomography, the CT scans. I'm going to refer to computed tomography as CT during this presentation. CT scans, they were not used regularly in dentistry, mostly reserved for treatment planning of complicated cases, maxillofacial surgery, head and neck diagnosis, possibly tumors. So these were the dedicated uses for the CT in dentistry. The reason for limited use of CT in dentistry was few limiting factors. First, the high doses of radiation and the cost, and accessibility. If you need CT scan for a patient, you have to send the patient to a hospital, and mostly the scan will not be on the same day. Patient need to take appointment. So it's time consuming to the patient, but when you send the patient for a CT, the result mostly will be interpreted by a radiologist in the center or in the hospital, and you will get the report. So this is how it worked. And overall, it was of limited use in dentistry, just for the absolute necessary cases because of those three factors. Then came the cone beam computed tomography, CBCT. And the first machine that was released for use was in 2001, although the development started in the late 90s. Now, where are the pretty pictures that were mentioned in the title? We said that we were having pretty pictures. Here they are. Well, look at those pretty pictures. Undeniable beauty, aren't they? They are only possible with the advances in imaging software, the rendering capabilities, and all these technological advances of the 21st century that enabled us to enjoy those really pretty pictures. But who called them pretty pictures? Who first called them pretty pictures? Well, it wasn't me, unfortunately. It was this man. This man is Professor John Ludlow from University of North Carolina School of Dentistry. And he is also affiliated with many radiological agencies and radiation protection agencies in the States. And he published extensively about CBCT specifically. He said that in one of his articles, if pretty pictures are being obtained when a just diagnostic image is needed, then we are doing our patient a disservice. And that concern was echoed by many radiologists worldwide. And this is why we want to talk a little bit more about those pretty pictures. Now, we took an oath upon graduation, which is first, do no harm. I'm sure you all guys remember this oath. Or maybe this is the way you say it: I will abstain from all intentional wrongdoing and harm. Regardless, the meaning is the same: do no harm. For those pretty pictures, there is a hidden cost, and I don't mean the financial cost. There is the exposure to ionizing radiation. What is X-ray really, and why we should care about ionizing radiation? X-ray is a type of ionizing radiation that is an energy. When the energy passes through the tissue, some of the photons in this energy could collide with the DNA material of the cell, and this collision results in damage. Now, what will happen after the damage? We have three possibilities. Either there will be cell repair, or the cell will die, or the cell will correct itself or repair itself incorrectly, so that there will be multiplication unhindered, and this gives rise to cancer or tumor. So only when the cell, after being hit by this photon loaded with this energy, we get incorrect repair. Here we have a possibility of multiplication and cancer development. The damaging effect of the ionizing radiation to the human tissues can be divided generally into two main categories: deterministic effect and stochastic effect. The deterministic effect is something mostly we can see and measure, and we know approximately at what level it happens. So it's something that is relatively measurable, and we have a range for when will this deterministic effect happen. It could be in a form of burn or damage to the eye. So the deterministic effect is something we can assess. However, the stochastic effect is governed by the laws of probability, and it may develop from any dose of radiation that are cumulative over time, any dose of radiation that's above zero or more than zero. So the stochastic effect being governed by probability law, this makes the distinction between what's safe and what's dangerous exposure to radiation almost impossible. Reason is we cannot measure it. We don't have the tools nowadays to measure that effect. That's why we assume anything above zero is not safe. The stochastic effect can be divided into cancer induction and genetic effect, but really genetic effect in dental imaging is negligible. So the focus will be on possibility of cancer induction. Now we need to minimize this risk. We need to minimize the risk of cancer development. To do that, we have to monitor the amount of radiation exposure. We have to monitor how much exposure we have to radiation. And to evaluate the influence of radiation on human body, we need a unit of measurement. We need measurement. We call this unit the effective dose. And this is a way to compare the dose and risk of radiation. This unit, that's the effective dose, is called the sievert. Now, for diagnostic imaging, usually it's expressed in millisievert or microsievert. We need also to remember that the effective radiation dose is directly correlated to the biological risk. We have evidence from literature linking exposure to low-level diagnostic ionizing radiation, doses used in medical imaging, to the development of cancer. I want to introduce a concept for you, which is a linear no threshold or LNT dose response relationship. Now, this concept is used to describe the relation between the radiation dose and occurrence of cancer. This dose response model, it suggests that any increase in the dose, anything above zero, no matter how small, could result in an incremental increase of the risk. The US Nuclear Regulatory Commission, the RNC, accepts the LNT, the linear no threshold hypothesis, because really it's a conservative model. And here we need to be conservative because simply we cannot measure how small is the dose that's capable of initiating or induction of cancer. That's why we adopt this conservative model for estimation of radiation risk. The latest report from the Nuclear Regulatory Commission, the report of 2020, still support this model. Now, because this agency support the model, followed by the International Commission on Radiological Protection, the ICRP, it's also support the linear non-threshold model, which is based on the principle of no non-threshold dose, and that any exposure to ionizing radiation still carries the possibility of causing damage. And this damage, unfortunately, includes cancer induction. But we need to remember also that the risk is proportional to the dose. I want you to look at this graph, on the right side and on the left side. This image explains the linear non-threshold model, the deterministic effect and the stochastic effect. You can see in the graph that explain the deterministic effect, which could be hair loss, cataract, skin injury, something we can see with our eye, a clear effect. You can see this period where there is no effect. So this is something we can estimate, we can measure. We know at which point those deterministic, mostly visible effect will start to appear. We have a threshold. So we can calculate beyond this level, yes, there is a risk. Below this level, we won't suffer the deterministic effect. So that's for this category. However, for the stochastic effect, we don't have this part of no effect. The possible effect could start at anything above 0. So when the dose goes, no matter how little, above 0, there is a possibility. Now, currently, we don't have the tools to measure how much above 0 we need to go for a possible stochastic effect. Could these tools be available in the future? Yeah, possible, but not now. And that's why the no threshold theory or conservative model is still adopted by many regulatory agencies. So this stochastic effect is something that we cannot see, like development of cancer, leukemia, hereditary effect. This is something we don't see until it is well developed. And this development usually doesn't happen the next day or the next week. It could be 1 decade or 2 decades or more. And this is what makes this assessment and measurement difficult. The United States Research Council of National Academies of Science, Engineering, and Medicine, they published an analysis of the low-dose radiation research, which concluded that the scientific research base shows that there is no threshold of exposure below which low levels of ionizing radiation can be demonstrated to be harmless or beneficial. Basically, the no threshold theory. We don't know the level where we will get stochastic effect. We assume anything above 0. I want to introduce another concept for you, the Alara concept or the Alara Principle. No exposure to X-ray or X-radiation can be considered completely free of risk. For this reason, it is recommended that the radiation dose should always be kept as low as reasonably achievable, which is the Alara Principle, the abbreviations of this principle. And this principle, you will see it in all radiation regulation worldwide. The assessment of the risks that are associated with the use of ionizing radiation for diagnostic imaging, this is an important public health issue. And this is why we are talking about it today. It's a public health issue. There are studies that provides evidence that links between the radiation from medical CT and cancer risk in children. In those studies, they found that children and young adults who received radiation doses of 2, possibly 3 CT scans of the head will have triple risk of developing leukemia or brain cancer in later stages of their life. Now, the medical CT, the head scan, it have an effective dose of up to 2000 microsievert. But most CBCT examination, they have much less effective dose. However, doses vary among CBCT units. Each unit, it's unique. Even if you are using the same field of view, let's say if you are using small field of view in one unit, maybe you will get 30 microsievert using a small field of view in another unit, maybe it will give you 100 microsievert. So that's why we cannot standardize how much each unit, how much all the CBCT unit possibly will give as a dose of radiation. So this implies that there is no safe limit or a safety zone for ionizing radiation. And this is for diagnostic imaging. Every exposure have a cumulative increase in the risk of cancer induction. Now, if we look at this table, it will help us to zoom in on the risk of cancer development to have a better perception. Now, I'm sharing this table with you that will show the risk of developing cancer from diagnostic X-ray. The upper part is the risk from 2D images. You can see, like for panoramic, it's 1 in 1 million. Cephalometric, 1 in 5 million. But when you go to 3D imaging, you see that the risk is a range, not a single number. And the reason for that is that the 3D machines, whether it's CT, CBCT, there are lots of variation, even for the same field of view, as we discussed a while ago. So a CBCT of small volume, the risk of developing cancer could be 1 in 2 million and up to 1 in 30,000, which is a considerable risk. I want to bring your attention to those two tables. They will help us appreciate the dose-related risk. So you can see the range of microsievert and effective dose for CBCT in comparison with the head CT. It could go up to 1,100 microsievert. And this is 3 times higher than the level of effective dose capable of producing 21 cancer cases per million of the population. So it shows a high risk and public health hazard. Another thing that's more alarming is that most studies show that those current figures possibly underestimate the risk by 90% to 300%. So if those figures from our point of view looks alarming, how about if they are underestimated by 90% or 300%? Because some studies claim that they are underestimated. One study looked at cancer risk specifically for CBCT. And the study concluded that the probability to develop a radiation-induced cancer with CBCT varied between 2.7 per million for age group that's over 60 to 9.8 per million to younger age group. Of course, the risk of radiation increase with younger age group. And the average will be 6 per million. And this is not medical CT. This is CBCT. Interestingly, the study shows that the higher risk group was in the orthodontic patient and in impaction patient, but less in the implant patient. And the reason for that is that patients undergoing impaction treatment or orthodontic treatment are usually in a much younger age group than the group that have implant treatment. So the younger we go, the more risk is to ionizing radiation. Also gender. This study finds that women are 40% higher risk of developing cancer-related exposure, resulting in cancer induction after CBCT examination. Now, maybe some of you is saying, yes, we knew about that, But if we are looking at the level of awareness, how much is the medical profession, dental profession, even radiologists, how much are they aware about those risks? Now, for awareness about radiation associated with medical imaging, previous studies concluded that radiation awareness among those groups, dentists, radiographers, students, radiology resident, radiography student, and medical students is inadequate, and that they have limited awareness about radiation protection. Those studies recommended greater emphasis should be put on the dental radiology course on both dentistry and radiography programs at the university. So we need to increase awareness. Now, another important factor that affects the radiation dose of CBCT, it's the field of view. Now, since the size of the field of view is proportional to the radiation dose, it's always recommended that practitioners choose the smallest field of view that's needed, or the aim of this particular digital dental X-ray modalities. So from this point of view, we should caution that CBCT is used only when absolutely necessary and for the diagnosis and treatment planning to minimize the amount of radiation to the patient. We use it only when the information we gain from this image will make a difference in diagnosis and in treatment planning and in our service to the patient. So here you can see in this table, it shows some range of mean adult effective dose in microsievert. We can see that CBCT, that is small field of view, can go up to 600 microsievert. Medium range CBCT or medium range field of view can give 674 microsievert. A large field of view of CBCT can expose the patient to over 1,000 microsievert. Now compare that with a panoramic or a cephalometric X-ray, and the difference is huge. Yes, it is lower than the medical CT, but if we are to gain the same result from two-dimensional images, then the choice is clear. The European Atomic Energy Community and the European Commission, they developed a project that's called SIDENTEC CT. This project is a radiation protection, evidence-based guidelines specifically dedicated for cone beam CT for dental and maxillofacial radiology. Now, this document is an excellent document. It gives extensive evidence-based guidelines for use of CBCT. And this document also recommends the using of a term called ALADA. A while ago, we mentioned the term Alara, which is as low as reasonably achievable. Now, this document and many radiologists recommend the use of ALADA, which is as low as diagnostically acceptable, which is even lower than reasonably achievable. Anyone looking for guidelines on using of CBCT, I really suggest looking at this document. It's freely available online. It gives detail about use of CBCT in all fields of dentistry and the strength of the evidence. If the evidence toward the use in a particular situation is strong, it will be stated. If the evidence is weak, also it will be stated. So it's not something general. It even grades how much is the strength of the evidence for against and for use of CBCT. It's really a good document. It also gives so much information about how to maintain the unit and what need to be done to adjust the unit for the practitioner and for the staff. Many studies highlighted that more evidence need to be produced on the cost effectiveness of CBCT for different diagnostic tasks. And in those articles, when they talk about cost effectiveness, they are not talking about financial cost. They are primarily concerned about the radiation dose. So many studies are counting the cost of this exposure to ionizing radiation. Now, we need to consider that the risk from dentomaxillofacial imaging is small on an individual level, but it becomes significant when it's multiplied by the large number of patients who are exposed to diagnostic imaging. Now, why the European Commission went into the trouble of developing this 170 document only dedicated for CBCT? What's so special about CBCT? Didn't we have three-dimensional imaging with CT scans? Why this alarm about CBCT? Now, CBCT captures the image in a different way, a different geometry than the medical CT. And this difference in geometry contributed to a smaller size machine, less expensive machine, and less radiation exposure. The available literature shows that it's used in all fields of dentistry. It also expanded the role of imaging from only diagnosis to image guidance of operative and surgical procedures. It also has a very unique feature. It's not hospital-based. It's available in the clinic, readily accessible. And the practicing dentist or physician doesn't have to send the patient to another center or to take appointment from hospital like the CT. They can have the scan immediately on the same day. And this accessibility is the reason of concern why there is a possible risk of overuse for CBCT. So here we're not calling not to use CBCT. On the contrary, we need to adopt new technologies, but at the same time, maintain the patient safety. And this is because we took an oath to do no harm. There is another alarming feature about the early starts of CBCT, which is how they were marketed in the early days and in the first decade of this century, between 2001 to 2010. When they were first released into the market, they were very much ahead of the regulations and the guidelines. They were first released to the market, and then the professional organization started to develop guidelines for this new technology, which we should have been more proactive, but that's the situation. Unfortunately, the profession is late to catch up with the development of technology. So the marketers had a head start before the regulators. And the way it was marketed is to display the features. It's office setting, which is true. It gives pretty pictures, 3D images, which is true. Less radiation than CT, which is also true, but they strategically forgot to mention that it's higher than 2D images. So if this particular diagnosis you're looking for can be achieved with 2D imaging, there is no reason to expose the patient to higher doses. Yes, it is less than medical CT, which was the only message given, but it's much higher than the 2 dimensions. Now, another alarming statement with the marketing of CT is that accidental finding, which really was implying like, take a CBCT anyway, you may find something, which is against all the guidelines of medical imaging. And medical imaging should not be, as one article put it, a fishing expedition. Besides, if it is office-based and it's the dentist that's going to interpret those images and not a radiologist, so possible accidental finding could be really missed. And that's why all the guidelines stress that whenever you take a CBCT, make sure to examine carefully and interpret all the image and record the finding, because you already exposed the patient to higher doses than two-dimensional images. So you might just as well use this image to its maximum. So accidental finding could happen, but if there is no expert eye to spot them, they will be lost. And we will be just left with pretty pictures. The other marketing tactic was that frequently mentioned is that your patient will be impressed by how modern is your clinic and you are using the latest technology, and that your clinic is better than the others, and you can share those pretty pictures with your patient. So these are some of the marketing tactics of CBCT. Now, maybe a practitioner would ask, how do I get guidance to give my patient the best service, yet not expose them to unnecessary doses of ionizing radiation? Where to get the guidance? Now, if we ask, do we need guidance? Then the answer is clear. Yes, we need guidance. We cannot just look at our patient and say, okay, from my personal experience, I will judge if this patient needs CBCT or not. Yes, we need guidance. Now, where to get those guidance? Now, since we need evidence, maybe one would think that the best guidance could come from articles in reputable dental journals in your respective specialty, where we can follow the author's opinion. This author has conducted a study or a systematic review, and they will give us an opinion whether to use CBCT or not in a particular situation. Now, let me share with you an example from my specialty, from orthodontics. The American Journal of Orthodontics and Dentofacial Orthopedic is a top journal in my specialty. In one issue, in the same issue of the journal, 2 articles about use of CBCT appeared, but with totally opposite opinion. The first article stated that cone beam CT technique is the technique of choice for comprehensive treatment. The second article in the same issue, cone beam CT is not the image technique of choice. So we may ask which one to choose. And I'm sure, regardless of your specialty, in your respective journals, you find similar articles where 2 different authors give contradicting opinion. One would be suggesting that it's better to use CBCT in all cases, and the other having a more conservative opinion and advice for caution in using CBCT. So it's not something unique for my specialty. It's just that because I'm familiar with it, I wanted to share with you. But these contradicting opinions continue to appear on scientific journal, dental scientific journals, and even sometimes it's a joy to look at the debates and discussions between experts from the States and expert from UK, one claiming that in UK you don't prescribe so much CBCT because it costs money, and yeah, those type of discussions. Now again, back to the guidelines. How about where to find guidelines. The International Commission on Radiological Protection, the ICPR, it regularly publishes reports and recommendations on radiation protection. And these guidelines are accepted worldwide, and they are used as a basis for national legislation. But the enforcement of those recommendations, it varies widely in different countries. For example, in the UK, the use of ionizing radiation in clinical practice is governed by criminal law. So it's something serious. But that's not the case in many other parts of the world. And guidelines continue to be published periodically, but they are not widely embraced. And the other observation about those guidelines is that some of them are consensus-based or expert opinions based on non-randomized clinical trials rather than randomized clinical trials. So this is another consideration for those guidelines. But if we are to ask, how are those guidelines developed? Usually they're developed in this way. A panel of experts are chosen by an agency or professional organization to draft guidelines. So those panel of experts, they will draft the guidelines based on their interpretation of available literature, the available evidence in literature, based on their experience through discussion and consensus. And that's why those guidelines differ slightly in their recommendations. Again, let me share with you one observation about radiation guidelines and regulation from my specialty, from orthodontics. We were conducting a review on the use of CBCT for placement of orthodontic mini screws, you know, those mini screws, the anchorage devices. So we were looking at articles and guidelines that recommend the use of CBCT for this purpose, placement of mini screw, the group that recommend and the group that's against. We find about 5 or 6 worldwide guidelines and recommendations for this purpose. All of them suggested that don't use. It's not recommended to expose the patient to CBCT just to place a mini screw. But there was one guideline that says, yes, it is recommended. And then this guideline cited 20 different articles that support the use of CBCT for placement of a mini screw. So we were wondering, how come there are 20 studies that support the use of CBCT for mini screw? How did we miss them? We conducted a review. Then we went back to those 20 articles in the guideline to see how did we miss those studies. Turns out from those 20 studies that were supposed to encourage the use of CBCT, only 5 out of 20 really recommended the use of CBCT for placement of mini screw, while the other 15 suggested that it is not recommended. So where does that leave us with guidelines? The reason I'm sharing this with you is that I would like to suggest that if you're in doubt whether to use CBCT in a certain clinical situation or not, to check more than one guideline, maybe a local guideline and an international guideline, or guidelines from different agencies or different continents. Check more than one guideline. This will possibly give you more guidance if you're in doubt. Also check if those guidelines have been updated. Some guidelines get recommended by another subsequent guidelines, which means that they are validated and double vetted. So if you find a guideline that was recommended by another guideline, this is a sign that the recommendation are validated and strong. So maybe you can use that. Especially if this recommendation came from another organization or another country. An example of a solid guideline is the one that I shared with you earlier, the SIDNTech CT project guideline. This guideline was recommended by the British Orthodontic Society guidelines, so double recommendation. And both those guidelines were praised and recommended by the editors of American Journal of Orthodontic and Dentofacial Orthopedic and the editor of Dentomaxillofacial Radiology journals. And both guidelines were described as a role model for other national guidelines. So the SIDNTech CT and the British Orthodontic Society guidelines were recommended as a model for other nations to draft their guidelines accordingly. And that's why, because their level of detail and thorough scientific approach. Other notable guidelines, there is the guidelines from American Academy of Oral and Maxillofacial Radiology, the American Dental Association Council on Scientific Affairs. They also have solid guidelines. The common recommendations that we find in all of those statements and guidelines is always follow the Alara Principle, as low as reasonably achievable, and using only what is needed for the diagnosis and treatment planning, the smallest field of view to reduce the patient exposure to radiation. One other important consideration that's always mentioned in all guidelines is training. Training of the machine operators, whether it's the practitioner himself or a radiologist or the staff that will deal with the machine. So training for machine operator, education for the operator. And it's worth noting that many reviews and studies observe that there is an increase in the use of CBCT in orthodontics, which is reflected by those guidelines, that specific guidelines for CBCT for the specialty of orthodontics were crafted. And all those guidelines concluded that there is no clear evidence to support the routine use of ionizing radiation in standard orthodontic diagnosis and treatment planning, including the use of CBCT, except when it is indicated. And the reason for focusing on the use of CBCT in orthodontics specifically is because of our patient, the age group of our patient. They are much younger than the patient who receive implants or other dental procedures. So this was the concern for orthodontist use of, or maybe sometimes overuse of CBCT. The previous guidelines recommends that the clinician's choice of the imaging protocol should be influenced always by the evidence or additional clinical benefits and guidelines of representative organization always depend on the guidelines to decide whether to use CBCT in a particular case or not, because ultimately this will translate to best evidence and best practice for your patient. So, can we pick one or maybe two guidelines to follow? What I would suggest for you is those two guidelines, because they are not specific for a specific field of dentistry. They deal with all fields of dentistry, and they constantly receive validation from other guidelines and systematic review, plus they stood the test of time. Or possibly you can choose your local guideline, your specialty guideline. But my personal suggestion, it's better to use two guidelines. When one doesn't mention a particular situation, there is a high possibility that you will find it in the other guideline. Now, to wrap the presentation, I would like to share with you some highlights and quick summary from those two suggested guidelines. Now, let's start with some general principles. Clinical examination should come always first. Never send the patient for radiological examination without first doing the clinical examination. And this is a common general principle in all guidelines. Examine clinically first and then decide whether you need further investigation or not. Then, this particular examination need to be clinically justified and not done just for screening purposes or routine, because really no X-ray examination should be routine. It should serve a purpose toward better diagnosis, better treatment planning, according to guidelines. Then we need careful consideration of the patient age group. Are we dealing with adolescent, a child? We need to adjust the dose accordingly. Also, it's very important to follow the as low as reasonably achievable, use the minimum field of view, and the CBCT should be interpreted fully and reported, because we already exposed the patient to high radiation dose. We want to use the information, all of the possible information, and record it for future reference. The other principle from all guidelines is that consult with a health physicist. And this is particularly important if the machine is in-house machine, it's in your clinic. So you cannot just install the machine and leave it. You need regular checking, standardization by a health physicist, and perform the quality control periodically. Now, before we wrap this presentation, let me give you a quick summary of the recommendations of those two guidelines. What's listed here is a possible recommendation for when to use CBCT. So those guidelines stated that may be indicated for impacted teeth, using always small field of view, assessment of cleft lip and palate, also indicated for skeletal abnormality, particularly when we need orthodontic surgical management, indicated for infrabony defects and furcation lesions. For periapical assessment, it only mentions selected cases where the 2D images contradicting with the clinical picture. So not all periapical assessment need three-dimensional imaging. Also selected cases of root canal, especially multi-rooted teeth, endodontic surgical procedures. More recommendation for selected cases of suspected root resorption, selected cases of dental trauma with root fracture, pre-surgical assessment of an unerupted tooth, possibly impaction of mandibular third molar relation to the inferior dental canal, implant placement, bony oral carcinoma, maxillofacial fracture, and orthognathic surgery. All those cases, the use of CBCT is recommended, and in some of them only in selected cases. And lastly, some key takeaways of this presentation is that CBCT is a great tool for diagnosis and treatment planning when used correctly. And the effect of ionizing radiation need to be considered We always need to weigh the risk and benefit and assess, and always observe the current imaging guidelines and look for update of those guidelines. And with that, I thank you.
Thank you very much, Dr. Nagham, for the excellent presentation. It was clearly presented, and of course, it finished on time, 1 hour as we estimated. So, from your, you have introduced various terms in your presentation just now, Alara, Alada, all these things. Well, some terms might be alien to us, but some of us might know what you're mentioning about. So, if you are, I don't see any questions from the chat box. Maybe it can be later. Maybe what is the safe? I mean, you said, you mentioned just now in your summary about implant to use can be used CBCT as opposed to the other one. You said selected cases, but implant we use CBCT. Is it all cases of implant or what?
The current guidelines, Prof, it stated that if the practitioner, when they are planning the implants, think that they need three-dimensional imaging or slicing images, then instead of using CT, definitely use CBCT. But if the practitioner think that the situation is clear, the bone assessment is clear, they don't need slicing imaging of the bone, then don't use CBCT. But most of the guidelines of the specialty of implantology now recommend using of CBCT as the best service. So maybe implantology is one of the areas where many guidelines agree that, yes, use it in almost all cases.
Okay, all right. Thank you very much. We have with Professor Malik. Want to ask our speaker tonight, Professor Malik?
Yes. Can you hear me?
A bit.
Sir, can you?
Yeah, we can hear.
Can you hear me?
Yes, we can hear you, Professor Malik.
Can you hear?
Yes, we can hear you.
It's a very excellent, very excellent presentation. Very excellent presentation. It is a talk of the town now, that CBCT. Once there was time that when in the initial stages OPG was introduced and people was fear about the radiation, and now it is very used to. Same is the CBCT, but the reservation of the CBCT is slight excessive radiation, and secondly, very expensive. And that she has mentioned as well. But it is good for the tertiary hospital. But slightly afraid to recommend it in the every general practitioner or every GP for this CBCT facility. I have slight reservation that this tool is not recommended for just a general practitioner. I think for the consultant or for the tertiary hospital, it is more necessary. And this is true that there's no doubt that era of three-dimensional slices is right there. So my reservation is just that it should be limited to the consultants only in the field of any field of dentistry.
Okay, thank you, Professor Malik. I just want to share with you and also our participants tonight that in Malaysia, to buy a CBCT, any practitioner who want to buy a CBCT machine has first to undergo a CPD course organized by our radiation agency in Ministry of Health. then
That's fine.
only they can use the CBCT.
And that should be the case, Prof. Yeah, that should be the case.
So they will know exactly when to use the indication. And they need to be trained, and when they pass, then they can buy the CBCT. So there is a mechanism to control, abuse of CBCT for our patient, unnecessarily to take our patient. And in our faculty, Professor Shah Malik, we have 2 CBCT machines, and every request of CBCT machine, our radiologists, our maxillofacial radiologists will look and design, okay, is it really needed, and if needed, what FOV will be recommended. So that's another screening at our faculty level. So that's a case that how, not to say we are limiting it, just to make sure that the use is appropriate of the CBCT machine, either on case or the.
Okay. Jato, I will like to add here, but in my institute, it is only me, dean or the principal. Dean or the principal is allowed to issue the permission for CBCT. Even not, we don't give permission to radiologists for the CBCT. They have to get the permission from the principal or from the dean. Because in Pakistan, it is slightly more expensive and more delicate that we cannot afford for every patient.
Yeah, okay. I mean, you must be very busy sorting out the request of. Okay, Dr. Nagham, you want to share about your PhD about measuring the thickness of bone and how to, from the study, and from that, I think you recommended which one to do is safest place to put implant, all these things, and without even taking a CBCT, Dr. Nagham?
Thank you so much, Prof. Dato. Yes, Prof. Dato was my supervisor during my PhD journey, so he's very well informed about this study. In fact, my journey in PhD was the thing that raised my awareness about CBCT. So we were trying to find ways where the orthodontist, in particular situation, which is the placement of orthodontic mini screw or the mini implant, does not need to use and expose patient to 3-dimensional imaging with CBCT. So we developed a model to measure the cortical bone thickness using machine learning and artificial neural network, specifically so that the orthodontist doesn't use CBCT for for just to place an anchorage device. From that, we became more interested in artificial intelligence modeling, which can serve the profession in similar situations and minimize other risky intervention or controversial practices. So now we're campaigning for more modeling, more artificial intelligence modeling in dentistry. But that may be the topic for another presentation on a Wednesday evening.
Yeah, definitely. I think you have, I know you have published a lot of papers. I mean, a few papers out of that. So again, maybe we can share that thing with our regular attender to our webinar about where is the safest place to put the tests. Although I'm not an orthodontist, but since I'm working with you about tests, you roughly know what are the safe location to put the anchorage device without taking any X-rays or CBCT or something like that. Maybe some of the time, Dr. Nagham, we can share this information.
We want to encourage the dentist to use more models, more modeling, especially now we have the artificial intelligence tools, so we can really develop robust and accurate models for prediction. So Maybe
Yeah,
we can share.
in the early days, in early 2001 or 2, where we are doing implants, we used to gauge the thickness of the bone by putting some mapping the thickness of mucosa and mapping, so we know how thick the bone remain to where to put an implant. So that was the days in 2000, before CBCT was introduced early years. So that was what we would, we learned from implant when the first implant was introduced a long time ago. Anyway, thank you, Dr. Nagham. I don't see any more questions, but there's Dr. Jaswan. I saw him putting up his hand. Maybe he accidentally put up his hand or not. I'm not sure. But I asked him, he did not answer. But anything else, Professor Malik, you want to ask the speaker, or we?
Actually, I will like to say that the same old story which you presented, Dhatu, that my professor, actually, he was very interested in implants. And he started implants in approximately 1980, you can say 1992, when he came from the England. And he was using the this implant of this was not a cylindrical implant, it was a blade vent implant system. That is blade vent implant system. And the same thing which you presented before in 2001 and 2, that you are wearing like that, he used to do for the OPG. And he used to measure the things, and for one implant, sometimes he has to take 2 or 3 OPG to get the accurate placement of the implant. So this CBCT has actually solved the problem very much, and it is a really blessing for the implantology now.
All right. I think that's all. Thank you, Professor Malik, for the comments, and of course, thank you very much, Dr. Nagham.
Thank you,
for
Prof. Dato.
Your experience, with us, and also, as I said, maybe we can invite you next time again to continue as the other part of your study to share. And on behalf of Section 15, I would like to thank you for your appearance tonight, and of course to all our participants who have joined us in the webinar. For me and Dr. Amy, or the committee members who are here in our leadership committee, again, thank you for you to join. And of course, as usual, we will introduce a speaker again, this time a bit late, but on 16th of March, Associate Professor Dr. Anna Purni Venkatiswaran. She will be talking about another interesting topic about verbal sedation, the art of hypnodontics. In UITM, we have sent a few of our lecturers to attend hypnodentistry. So Dr. Anna is one of the staff who has sent, and we have set up a clinic, and we also conduct some courses on hypnodontics. So please join us on the 16th of March, where Dr. Anna Purni, a senior lecturer, associate professor, will share with us about verbal sedation. So remember the date, 16th of March, 9:30. Hope to see you again for these very catchy, interesting topics. And again, on behalf of Section 15, I would thank all of you who has joined us tonight. And we meet again on the 16th for our next webinar. Thank you. Good night, and have a good rest wherever you are. Of course, in Malaysia, it's quite late now, almost 11 o'clock. Thank you, and see you all later for this webinar. Thank you.
Thanks to all, and thank you, Prof. Dato.
Thank you. Welcome. Thank you very much. Amy, thank you for being for sitting here tonight. Okay, Professor Malik, see you in our webinar.
Thank you, Prof. Good night.